Greetings and a warm welcome to all the dignitaries present here. I'm Swashi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of engaging services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event, hosted by the Indian College of Anesthesiologists. And the focus of today's session is ERAS in cardiac surgery. So let's begin today's session, for which I'd like to invite Dr. Muralidhar Kansi sir to take over. Over to you, sir.
Thank you, Shreyasi, for providing this opportunity to do the scientific session on the Clarinet platform. Thank you so much. At the outset, I would like to welcome the participants and the attendees to this Wednesday ICA webinar, which is a hallmark of Indian College of Anesthesiologists. As you may be aware, Indian College of Anesthesiologists was registered in the year 2008, and it has grown subsequently, and its main focus is on academic advancement. And with this intention, the ICA, that is Indian College of Anesthesiologists, has established a weekly webinar on Wednesdays from 7 to 9, which has been happening from the last 5 years and more than that, which has become very popular and attractive to the trainees as well as to the practicing anesthesiologists. With this background, the ICA is also involved in conducting fellowship programs in various subspecialties of anesthesia, and it conducts annual conferences. It has its own journal, and the yearbook is also a very prominent feature of this ICA academic activities. And the perioperative echocardiography and critical care echocardiography fellowships have become very popular. And through that forum, we conduct Sunday breakfast sessions in echocardiography. It gives me great pleasure to invite Dr. Rajesh Kumar Chand as the chief moderator for this session, and he will be assisted by Dr. Lakshmi Patil. Dr. Rajesh Kumar Chand, as you may be aware, is a highly experienced cardiac anesthesiologist with over 35 years of experience in perioperative and critical care of cardiac patients. He is the senior director of cardiac anesthesiologist at the Super Specialty Hospital Saket in New Delhi. And he is the president-elect and senior vice president of the Indian Association of Cardiothoracic Anesthesiologists. He is well known for his expertise and erudite scholarship in the field of cardiac anesthesia, and we are grateful that he has joined us today with his team to deal with this important subject of early recovery after cardiac surgery. And Lakshmi Patil is my colleague. She is also an accomplished cardiac anesthesiologist, has been in this field for over 20 years, and academically orientated, and patient caring attitudes are her attributes. With that, I would request Dr. Rajesh Kumar Chand to take over. Before I do that, I request the participants to keep their mics in mute mode till the end. And if you want to ask any question at that point of time after the at the end of the talks, you may please unmute and then speak into the meeting. Any questions and comments may be posted in chat box. We will address them at the end of the meeting. And with that, I would request Dr. Rajesh Kumar Chand to take over the proceedings, and we are looking forward to that. Dr. Rajesh Kumar, please carry on with the session.
Good evening, sir. Thank you very much for your kind words and your encouragement, and thanks for giving us opportunity to present this topic. Today we'll be talking about ERAS in cardiac surgery, So it is already well known to us that ERAS, enhanced recovery after surgery, it has given creditable and predictable results after GI and colorectal and orthopedic surgeries. So same, the application is being tried and attempted. So today, our set of speakers, starting with Dr. Rohit, followed by Dr. Saurabh and Dr. Bhuvnesh, and then finally by Dr. Rahul to bring up the evidence. So we will try to go into the details of subtopic and see how we can apply and whether we can apply it to cardiac surgery. So with this, now I invite Dr. Rohit Bhatia to share his thoughts. Dr. Rohit is a principal consultant at Max Super Specialty Hospital, Saket. Uh, and I'm sure he is going to make us wiser by what he has to say about ERAS in cardiac surgery prehabilitation. Dr. Rohit.
Thank you, sir. Good evening, everyone. So I'll be starting my talk now. So I'll be discussing briefly about prehabilitation for ERAS for cardiac surgery. And just a minute. Are my slides visible? Press the button.
Yes, I can see the slides.
Just a minute, sir. But I'm not able to see, unfortunately. I don't know what happened.
We can see the slides.
Okay, sir.
Yes.
Am I audible?
Yes, yes.
Okay, sir. So I'll be discussing about the prehabilitation for ERAS for cardiac surgery. As we all know, ERAS is enhanced recovery after surgery. So it is a multimodal transdisciplinary care improvement initiative to promote the recovery of patients undergoing surgery throughout their entire perioperative journey. And the protocols mainly aim to reduce the complications and promote an early return to normal activities. In early studies, the ERAS approach showed promise in cardiac surgery. However, still we need evidence-based protocols, and they have yet to emerge. Now, ERAS, in all over the centers, it is firmly established as a global surgical quality improvement pathway. The results, they really improved the clinical outcomes and reduced hospital stay, translating into reduced healthcare costs. ERAS is a complete gamut of perioperative care. So it involves both preoperative, intraoperative, as well as the postoperative care. Coming on to the history of ERAS, well, the concept was pioneered in the late 1990s by a Danish surgeon, Kellet, whose initial work mainly focused on colorectal surgery. Only recently, the principles of ERAS have been adapted to cardiac surgical specialty. ERAS Cardiac Society was formed in 2017 with first... Hello.
ఎక్కడికి వెళ్ళొద్దని చెప్పాను కదా.
So ERAS Cardiac Society was formed in
రమ్మంటావా
2017 with first expert consensus coming in 2019
ఇంటికి రావాలి.
with recent guidelines coming as early as 2024.
ఒంట్లో బాగాలేదని చెప్పి ఇంట్లో
Now, what are the key pillars of preoperative ERAS? Well, preoperative ERAS mainly involves a proper education of the patient, which includes comprehensive counseling to manage expectations and reduce anxiety. Nutritional rehabilitation, which mainly involves carbohydrate loading and nutritional screening. And lifestyle modification. The two main things in this is smoking and alcohol cessation, which really minimizes the post-operative complications. Coming on to the pre-admission counseling, well, it mainly involves to manage the expectations. There has to be a detailed explanation of the surgical procedure, pain management strategies, and clear discharge criteria, which really helps patients prepare mentally for the journey ahead. We have to reduce anxiety. So there has to be a clear plan, accessible information, which really significantly blunts the surgical stress response. We have to remember that an informed patient is less anxious and more compliant with the recovery protocols. Now, this is a approach. This approach is called as the new approach, which is a key pillar of prehabilitation. It involves the nutrition optimization, which stands for N, exercise training, E, and anxiety or worry reduction, which is W. So it is a new approach. Coming on to the patient education and counseling. Well, it is a strong ERAS recommendation. There has to be a detailed explanation of surgical procedure and expected recovery, early extubation, early mobilization and pain control plan, and nutrition and glycemic control. What are the benefits? Well, it decreases the anxiety and increases the compliance of the patient. Now, prehabilitation is generally initiated in the outpatient setting 2 to 6 weeks prior to elective surgery where it is feasible. Adapted physical exercise or APE is a cornerstone of this approach. Now, what can we do in nutritional optimization? We have to screen every patient if possible for malnutrition. There has to be a protein supplementation, and this protein supplementation should start around 7 to 10 days in the preoperative period. Prolonged fasting has to be avoided. The traditional NPO after midnight, it depletes the glycogen reserves and increases the insulin resistance. The goal of this nutritional optimization is to keep the patient in an anabolic state rather than a catabolic starvation state. Nutritional prehabilitation and optimization. Now, we all know that malnutrition and poor nutritional status, these patients, they face increased risk of post-operative complications and higher mortality rates. So nutritional prehabilitation, it seeks to correct the deficits, build the metabolic reserves, and enhance the patient's ability to withstand the surgical trauma. Now, why nutritional prehabilitation is required? Surgery, it mainly creates a significant metabolic burden, include inflammation, oxidative stress, and catabolic processes. Surgical stress induces a state of hypermetabolism and insulin resistance, which results in delayed recovery due to excessive protein catabolism and impaired glucose regulation. Now, this in turn leads to delayed recovery due to muscle wasting and immunosuppression. Assessment and treatment of pure nutrition is an essential component of ERAS prehabilitation protocols. Correction of preoperative nutritional deficiencies, it may sometimes require prolonged parenteral or a combination of parenteral and enteral nutrition. Role of an expert nutritionist in this aspect is very important. Now, nutritional prehabilitation advantages, well, it results in superior wound healing. It abates the surgical site infection. It curtails the duration of mechanical ventilation and reduces the length of stay in the hospital and hence early recovery. Another advantage of nutritional prehabilitation is that it addresses the insulin resistance primarily through preoperative carbohydrate loading, and thus it counteracts the insulin resistance. Now, controlled loading of carbohydrates 2 to 3 hours before surgery, it is hypothesized to stimulate the insulin secretion, and it prevents insulin resistance and helps in reducing the need for gluconeogenesis and preserving the muscle protein stores. Carbohydrate loading, it's a very important aspect of nutritional prehabilitation. As discussed, it attenuates the post-operative insulin resistance, and it preserves the skeletal muscle mass, reduces preoperative thirst, hunger, and anxiety. How do we do that? How we should do that? Now, the ERAS cardiac guidelines, they recommend 800 ml of a 12.5% carbohydrate clear drink the night before and 400 ml of the same fluid 2 hours prior to surgery. It is an important component of ERAS protocol and it should replace overnight fasting. Now, coming on to the fasting and carbohydrate loading. Well, solid foods, they can be allowed up to 6 hours before induction of anesthesia. Clear liquids, we can allow up to 2 hours of clear liquids up to 2 hours before induction, which can be water, pulp-free juice, tea or coffee without milk. And as I mentioned earlier, a complex carbohydrate drink, which is typically 25 to 50 grams of maltodextrin-based formula, it can be given to the patient with 300 to 400 ml of water around 2 hours before induction of anesthesia. What are the benefits? As I discussed before also, it reduces the thirst, hunger, and most importantly, anxiety, while shifting the metabolism to a fed state. If we compare the traditional versus ERAS protocols in the preoperative period, well, in the traditional protocol, fasting has to be from NPO, but in ERAS protocol, we can continue solids up to 6 hours and liquids up to 2 hours. Carbohydrate loading, well, there is no role of carbohydrate loading in the traditional protocol, but we can give complex carbohydrate drink 2 hours preoperatively in the ERAS protocol. Bowel preparation, routine mechanical preparation in the traditional protocol, there is none or it can be a selective preparation in the rectal surgery. Pre-medication, Long-acting sedatives were given in the traditional protocol, but they have to be avoided and they should be avoided in the ERAS protocol. Advantages of carbohydrate loading. So, to summarize, the most important advantage is that it reduces the insulin resistance and it improves the post-operative glycemic control. It minimizes protein and muscle loss. The gut mobility returns to normal faster with less incidence of post-operative ileus, and it preserves the immune function. Where is to be avoided? Where there are 4 instances where this carbohydrate loading has to be avoided: in the patient with severe gastroparesis, in the patient with severe gastrointestinal reflux disease, in emergency surgeries, and if the patient has severe diabetes due to different insulin dynamics. Now, what is the advantage of immunonutrition? Well, immunonutrition, it modulates the inflammatory response. Arginine, omega-3 fatty acids, and glutamine, they are an integral part to this process. Ingredients: the macronutrients such as zinc, selenium, and vitamins A, C, and D, they play critical roles in supporting immune function during the perioperative period. They help in preserve the muscle protein stores, because we all know that surgical stress, it accelerates the muscle protein breakdown due to elevated glucocorticoid levels and systemic inflammation. Branch chain amino acids, particularly leucine preserves the muscle mass and strength. Adequate protein intake, and if possible, whey protein, which is rich in essential and branch chain amino acids, it helps in tolerating the surgical stress and facilitates faster recovery. Another advantage is that although limited data is available, but prehabilitation strategies are hypothesized to support the gut health. Dietary fibers, prebiotics, and probiotics, they play an important role in this aspect. Probiotic strains like Lactobacillus, Bifidobacterium, they are thought to enhance the gut barrier integrity. These interventions, they may reduce systemic inflammation by limiting endotoxin translocation and modulating the immune responses. Another important aspect as far as the nutrition is concerned is the preoperative albumin levels. Well, hypoalbuminemia is associated with an increased risk of morbidity and mortality in the postoperative period. It can definitely increase the ventilatory time, acute kidney injury, infection, and longer length of stay in the hospital. Patients undergoing cardiac surgery who had a serum albumin level less than 3 grams per deciliter, and if there was a supplementation with 7 to 10 days worth of intensive nutrition therapy, it may improve outcomes. Correction on nutritional deficiency is therefore always recommended when feasible. We have to treat preoperative anemia if it is there, because it is prevalent in around 40% of the surgical patients. It is critical in minimizing post-operative complications and enhancing early recovery. The role of exercise in nutritional prehab. Well, physical training complements the nutritional interventions by improving the body's ability to utilize energy sources efficiently, thereby increasing the cardiovascular fitness and preserving the muscle mass. Aerobic exercises like walking, cycling is a cornerstone of rehabilitation. It significantly enhances the cardiovascular capacity. It also has an anti-inflammatory effects. Resistance training, often combined with aerobic components, it is integral to preserve and enhance the skeletal muscle mass and strength during prehab. Advantages: well, it decreases the sympathetic overactivity, it improves the insulin sensitivity again, and increases the ratio of lean body mass to body fat. It improves the physical and psychological readiness for the surgery, reduces the post-operative complications and length of stay. Now, 3 non-cardiac surgery studies have successfully demonstrated the benefits of 3 to 4 weeks of prehabilitation in the context of ERAS. Prehabilitation interventions prior to cardiac surgery must be further examined to advance this area of research. It is especially beneficial in this exercise training in elderly patients, in frail patients, and in COPD patients. 2 key aspects of lifestyle modification which we can do for prehabilitation is smoking cessation. Smoking ideally should be stopped at least 4 weeks prior to surgery. This significantly reduces the risk of respiratory complications and poor wound healing. Abstaining from alcohol in the preoperative period, it again reduces the rate of postoperative complications, including infections and bleeding episodes. Another important aspect in the preoperative nutritional prehabilitation is the HbA1c levels in diabetic patients. Many studies have shown that if the HbA1c levels are less than 6.5%, they have been associated with significant decrease in complications, and hence enhanced recovery. Hypoglycemia obviously should be avoided. we have to continue the basal insulin with dose adjustment, and SGL2 inhibitors should be stopped at least 3 days in the preoperative period. If we talk about pre-medication, well, benzodiazepines should be avoided completely, particularly in the elderly. Some recent guidelines and studies have shown that pregabalin at a dose of 75 milligram is effective in reducing post-operative morphine requirements and also helps in reducing anxiety and apprehension in the preoperative period. So it can substitute benzodiazepines. Now, what are the level of evidences and strength of recommendation? Prehabilitation, well, strength of recommendation is moderate, class 2A, and level of evidence is level BR, non-randomized. Clear liquids until 2 to 4 hours of surgery, like I mentioned before. Again, the strength of recommendation is weak, class 2B, and level of evidence is level CLD, that is limited data is available. Preoperative carbohydrate loading, strength of recommendation is weak, class 2B, and level of evidence is CLD, that is again limited data is available. Smoking and alcohol cessation, on the other hand, well, there is a strong strength of recommendation, class 1, and level of evidence is CLD, limited data. To have preoperative FG1AC levels less than 6.5%, strength of recommendation is moderate, class 2A, and level of evidence is CLD, limited data. Preoperative correction of nutritional deficiency, strength of recommendation is moderate, class 2A, and level of evidence is CLD, limited data again. So to summarize the prehabilitation for ERAS protocols, well, it is a multimodal approach. Successful delivery of prehabilitation, it requires a coordinated multidisciplinary effort involving surgeons, anesthesiologists, physiotherapists, dietitians, and psychologists. Adapted physical exercise, when combined with nutritional and psychological interventions, it improved the cardiovascular function, resilience, and accelerated post-operative recovery. While prehabilitation has established role in various non-cardiac surgeries, its application in cardiac surgery is less well defined due to lack of large, high-quality trial data. Despite these challenges, the role of prehabilitation in cardiac surgery, it has been identified as a research priority. Thank you.
Thank you, Dr. Rohit. Now I will request Dr. Saurabh Pandey to talk about application of ERAS in the intraoperative and postoperative phase. Dr. Saurabh is he's also a principal consultant. He was with us till recently. Just a few days back, or 1 or 2 weeks back, he has joined another hospital in Delhi NCR, that is Fortis Noida. And Dr. Saurabh, please make your presentation. Thank you.
Saurabh, please unmute yourself.
Saurabh, you need to unmute yourself. On your screen, you need to unmute. You are muted.
Okay.
Thank you. Thank you. And now share your presentation.
Okay. Thank you very much, sir, for kind introduction and inviting me for this talk. Whether my slides are visible or not, sir?
They are visible. Yeah, visible.
The slides are visible. You have to blow it up.
Okay, sir. Is it okay now?
Yes, yes. Now.
Yes. Okay. So good evening all. Now I would like to talk about ERAS, enhanced recovery after cardiac surgery. And as we all know, ERAS is a multidisciplinary approach which involves the principle of protocolized evidence-based perioperative intervention to improve clinical outcomes. So till now, we as an anesthetist, we all many times do fast track cardiac anesthesia. It's the same principle ERAS also follows. So it's a technique that allows early extubation, early mobilization, and we general principles we use we use short-acting muscle relaxants rather than long-acting, correction of hypoalbuminemia preoperatively, as Dr. Rohit already said. And we reverse the patient after surgery with myopilates, and we use high dose. We avoid high dose opioids and try to use low dose or moderate dose opioid or non-opioid medications for pain and pain reliefs and analgesia. So, and similarly in post-operative phase, we also consider early extubation for fast track in case of fast track cardiac surgery recovery, and multimodal analgesia, goal-directed fluid therapies, early removal of lines, tubes, and during surgery or even after surgery, we can use dexmedetomidine and acetaminophen also. So now, to the first joint consensus statement given by ERAS Cardiac Society, ERAS International Society, and STS together gave first cardiac consensus statement on 2019, and which was updated on 2024, which highlighted the interoperative process measures for ERAS. So if we go through the recommendations of ERAS societies, the first one is usage of transesophageal echocardiography. So role of TE in valvular and congenital surgeries are well established and is associated with significant reduction in stroke, reoperation, and 30-day mortality. However, in TE in CABG is associated with limited prior investigations. And one of the recent observational study of more than 1.3 million patients showed that TE helps in significantly reduces the postoperative mortality in moderately risk patients, and it positively influences surgical and anesthetic decision makings during cardiac surgery. So the final statement given by the ERAS Society is that TE is encouraged in patients with moderate or high risk of perioperative morbidity or mortality, and the quality of evidence is moderate. The other one is protective lung ventilation. We all talk too much about the protective lung ventilation strategies, and many observational studies and randomized control trials data suggested that they have given those studies in non-cardiac surgical patients, and which we have adopted in cardiac surgeries also. That includes low tidal volume ventilation, includes 6 to 8 ml per kg predicted body weight, along with PEEP and alveolar recruitment maneuvers. And all these maneuvers helps to reduce postoperative pulmonary complications. However, the modern lung protection ventilation strategies emphasizes more on lower driving pressures, that is PEEP inspiratory pressure minus PEEP, and it should be less than 16 centimeter S2, along with lower tidal volumes and PEEP of more than 5 centimeter S2. So ERAS protocols follows modern lung protection ventilation strategies with more focus on lower driving pressures. So final summary statement given is that mechanical ventilation with lung protection strategies associated with improved mechanics and fewer pulmonary complications, and quality of evidence is high. Now come to our for ventilation on cardiopulmonary bypass. So many anesthetists use CPAP during on CPB to improve the post-op gas exchange, and it prevents post-op complications also. However, several studies didn't find a difference in post-op complication between the ventilation and non-ventilation strategies. And so the summary statement that role of mechanical ventilation during CPB is uncertain, and quality of evidence is moderate. Now we talk about the pulmonary artery catheters. So and it is considered safe and potentially beneficial in these kind of patients. In low risk patient, it is said that it increases interventions, non-routine vasopressor use, fluid and excessive fluid administration, and it also incurs greater healthcare expenses. So the statement is like from ERAS society is that PAC used in low risk patients and procedures incurs greater healthcare resource utilization without improving morbidity and mortality. And level of evidence is again moderate. Now, CNS monitoring, CNS with CNS monitoring, we use an IRS and EEG, which identifies and helps to prevent periods of brain malperfusion and ensure adequate titration of anesthetics, to prevent post-op neurocognitive dysfunctions and avoid excessive depth of anesthesia. However, the management of cerebral hypoperfusion is wide-ranging because it includes blood transfusions, supplemental oxygens, vasopressors. So its role is unclear about optimal interventions to which patient requires which intervention, and it really helps. All these interventions really helps in that kind of cases is still unclear. So final summary statement from ERAS is that CNS monitoring may provide an early indication of neurological risk, but additional study is necessary to identify strategies to prevent and mitigate injury. Again, the level of evidence is moderate only. PONB, postoperative nausea vomiting prevention, again, its incidence ranges from 10% to 70%. And the prophylactic treatment, many studies have shown that it reduces 20% reduction in the incidence of PONV. So PONV recommends screening of risk factors, administration for patient-specific prevention and rescue strategies, and inclusion of multimodal PONV risk prophylaxis in ERAS. Every patient has different risk factor, and prophylaxis is also based on number of risk factors. The four major factors which are identified for PONVs: female sex, non-smoker, history of PONV or motion sickness, and post-operative opioid use. And antiemetics are administered accordingly. In one study, they administered dexamethasone 5 mg along with ondansetron, and they found that it significantly reduced the PONV in cardiac surgery patients. So the summary statement is standardized risk factor assessment and prophylaxis has been shown to prevent postoperative nausea and vomiting, and again the level of inhalation is moderate only. Now the goal-directed perfusion. So routinely on CPP, blood flow is based on that blood flow on CPP correlates with cardiac index with body surface area measurement. In ERAS, there is a formal algorithm to protocolize for flow rates and hemoglobin levels and vasopressor titration to achieve a targeted delivery of oxygen. So they have given emphasis on targeted delivery of oxygen threshold. So it is said that initial research historically said that maintaining delivery of oxygen 280 ml per minute per meter square on CPP with moderate hypothermia is associated with reduction in incidence of acute kidney injury in stage 1. However, low DO2, low delivery of oxygen on CPP may associate with greater morbidity and mortality after cardiac surgery if DO2 level is less than 280 ml. So the GTP approach did not significantly affect the impact on stage 2 and 3 kidney disease, but it definitely has a reduction in the incidence of acute kidney injury phase stage 1. Summary statement is goal-directed perfusion may play a role in preventing organ injury associated with cardiopulmonary bypass, and the quality of evidence is low. Post-operative process measures. Early extubation strategies in case of post-operative, they have given some after intraoperative, they have given some post-operative. ERAS society has given post-operative process measures also. The first one is early extubation strategies, which is considered as less than 6 hours after surgery in cases of low risk and certain high risk aortic surgeries also, ascending aortic repairs. And these measures are applied on elective cardiac operations and avoided in emergency to cardiac operation. And finally, these studies suggested that early extubation strategy is safe and with reduced intensive care and hospital length of stay. And there is, although there is no difference in the mortality. The summary statement for this early extubation strategies, if we facilitate extubation within 6 hours of surgery, it is considered as safe and potentially hasten recovery after elective procedure. The other one is intraoperative extubation. Studies have reported that intraoperative and immediate postoperative extubation is considered as within an hour of surgery, and it is feasible, it is possible, and it is safe also in selected patients, and it incurs 20% reduction in cost of care also, and it also reduces the hospital and ICU stay. And studies have also reported that re-intubation and overall complication rates are compared with standard extubation protocols. So the summary statement is highly selective intraoperative or immediate postoperative extubation may be appropriate for patients undergoing low cardiac surgery, and the quality of evidence is again low. The very much discussed topic is acute kidney injury after cardiac surgery, and the incidence is as high as 20 to 40%. And it increases the risk of chronic kidney disease also, and increases short-term and both long-term mortality. So the early implementation of KIDIGO care bundles has given some measures to reduce the kidney injuries. KIDIGO is kidney disease improved global outcomes. So they have given some points like serial monitoring of serum creatinine, strict urine output quantification, volume replacement based on advanced algorithm, maintenance of hemodynamic targets, avoidance of nephrotoxic agents. And they found that these measures reduces the rate of stage 2 and 3 AKI after cardiac surgery. However, the limitation of KIDIGO staging system is that serum creatinine and urine output are surrogate markers of GFR and not specific to AKI, because in healthy kidney, the GFR as by creatinine may not decrease until 50% of the nephrons are lost. And after surgery, volume overload also sometimes falsely indicate normal creatinine values. So there are some novel kidney biomarkers also which may predict and detect AKI before rise in creatinine. Preoperatively with urinary uromodulin levels, and postoperatively tissue inhibitor of metalloproteinase and insulin-like growth factor binding protein 7 can predict the development of AKI. Final summary statement is routine screening for and where appropriate, the use of comprehensive treatment care bundle can reduce the incidence and severity of post-op acute kidney injury, and the quality of evidence moderate. Now, coming to post-operative activity and external precautions. The early post-operative ambulation and physiotherapy exercises like cycling or walking, muscular exercises and other activities in the initial 24 hours after surgery hastens recovery and reduces readmission, improves quality of life. Along with early physiotherapy, ERAS protocol has emphasized on upper extremity exercises also, and it allows for greater range of motions based on patient comfort. So as compared to restrictive external precautions, early and as an alternative, early upper extremity exercises are encouraged. So summary statement is early post-operative ambulation and upper extremity exercise is well tolerated and associated with fast recovery. Again, quality of evidence is moderate. So there are some multiphasic process measures also given by ERAS. The first one is goal-directed therapy. So there are some goal-directed hemodynamic fluid therapy measures that identifies responsiveness to fluid administration. That includes stroke volume variation, pulse pressure variation, cardiac output and stroke volume responsiveness to fluid challenge, TE guided volume status. And however, there is so much of clinical heterogeneity, and the results are inconsistent in different patients. Some patients respond, some patients do not respond. So, because of non-universal results, we cannot comment on the evidence is moderate only, because we need to get some hemodynamic endpoints through the provision of fluid and vasopressor titration. So goal-directed fluid and hemodynamic therapy can guide perioperative resuscitation and prevent postoperative injury. The one more is opioid sparing pain management. So opioid is considered as to enhance post-op nausea, vomiting, and it is important to make the patient pain-free because of pulmonary complications, otherwise, or cardiovascular complications because of intrinsic sympathetic increasing activity, sympathetic activity, to reduce post-op delirium and to reduce chronic pain syndromes. Because if any pain persists for more than three days, it may turn into the chronic pain also. So it's important to make the patient pain-free during and after surgery. But there is a more focus on reducing the reliance on opioids, which facilitates early and because non-opioid management also facilitates early extubation, shorter length of stay, and it has less PONV incidences as compared to opioid treatment. So summary statement is multimodal approach reduces reliance upon opioid-based analgesia and optimizes perioperative pain management. So quality of evidence is again moderate. There's one more thing, regional anesthesia. We all, many anesthetists uses thoracic epidural or different kinds of blocks like rectus spinae, paravertebral block, and other paraspinal and chest wall regional anesthesia techniques. As an alternative to opioids and as a multimodal analgesia. So in a meta-analysis consisting in 69 trials with and included 4,860 patients with thoracic epidural showed that thoracic epidural analgesia reduced pain, intubation time, lower respiratory depressions, and having lower arrhythmia rates in patients who have received thoracic epidural. So summary statement final given by the ERAS Society is chest wall regional analgesia is an effective component of multimodal approach to perioperative pain management. Again, the level of opinion is moderate. The next is patient blood management program. Patient blood management consists of three major points to see, like one is preoperative anemia and iron deficiency screening and optimization. That is preoperative, intraoperative to minimize blood loss and hemodilutions, and there is permissive intraoperative and postoperative anemia. So they have given several measures to do for the preoperative anemia. Healthcare providers should be a part of comprehensive strategy to avoid unnecessary transfusion. The screening for any iron and anemia and iron deficiency assessment, and preoperatively on to be done preoperatively, and treatment with B12, folate, and IV iron preparation as indicated is reasonable to reduce blood transfusion. Similarly, intravenous iron and erythropoietin is also reasonable to increase red cell for anemic patients if we can wait for elective cardiac surgery. The other one is minimize blood loss and avoid hemodilution during intraoperative cardiac surgery with the help of tranexamic acid and EACA and other measures like reduce priming volume during in the CPP circuit, use of retrograde autologous priming of the CPP circuit, use of cell savers during cardiac surgery, and standardized hemostasis checklist during cardiac surgery before closing can reduce bleeding and blood transfusion. In the postoperative and intraoperative period, permissive anemia is also followed, like standardized restrictive perioperative red RBC transfusion protocol is favored in preference to liberal strategy to reduce transfusion, and goal-directed transfusion algorithms to be followed. And if the targeted hemoglobin concentration is more than for blood transfusion is more than 7.5. The summary statement is blood product use and associated outcomes are optimized through the implementation of a comprehensive patient blood management program and level of quality of evidence moderate. Again, the atrial fibrillation is the most distressing thing for the patient and for doctors both. And POF after cardiac surgery has incidence quite high, ranging from 15 to 40%, in associated with increased risk of stroke and early and late mortality, and again increased length of hospital length of stay and cost. So finally, CHAD's VAST2 score has been shown to be an independent predictor of the development of POF. And it includes scoring system. CHAD's VAST2 includes hypertension, congestive heart failure, hypertension, age more than 75 years, diabetes mellitus, stroke, coronary and vascular surgery, age 64 to 75, and different parameters have given different scoring system, and female sex. So it includes preoperative and immediate postoperative oral or IV beta blocker, and preoperative or immediate postoperative intravenous amiodarone needs to be started, and other procedural consideration like posterior pericardiectomy and avoidance of retained pericardial blood. Again, the treatment against the inflammatory state is thought to be implicated in post-op atrial fibrillation, and multiple randomized trials have been conducted looking at they have used many medications for AF treatment, like corticosteroid and N-acetylcysteine, polyunsaturated fatty acids, and vitamins. However, the routine use of magnesium supplementation has not been shown to be beneficial for prevention of postoperative atrial fibrillation. One of the major factor implicated for AF is pericardial effusion. So they have ERAS Society has recommended to avoid retention of pericardial blood, and posterior pericardiotomy has demonstrated a reduction in residual pericardial effusion as well as POF. Final summary statement is postoperative atrial fibrillation is optimally addressed through the use of multifaceted prevention strategy, quality of evidence moderate. One more complication like systematic delirium screening and prevention. Incidences as high as 20 to 50%. The early, in case of early delirium detection, the preoperative phase, we need to identify key risk factors, and in postoperatively, systemic delirium tool needs to be implemented. We need to see in the ICU that how the patient presents, like it is hypoactive, hyperactive, or mixed, and these are the routine. It includes as a routine monitoring for once per nursing shift. Once the delirium has been identified, now we need to determine the underlying cause also, whether it is because of the chronic consistent pain, hypoxemia, low cardiac output, or sepsis, and for that we need to initiate appropriate treatment also. ERAS Society has also incorporated the ABCDEF liberation bundles, where A is assess, prevent, and manage pain. B is both spontaneous awakening and spontaneous breathing trials while patient is on ventilator. C is choice of analgesia and sedation. Appropriate and multimodal analgesia, as I suggested, is preferred. D is delirium, to assess delirium, prevent and manage during ICU, in the ICU. And E is early mobility and exercise. F is family engagement and empowerment in the post-operative cardiac surgical ICU. So the summary statement is routine use of a systematic delirium screening tool and non-pharmacologic strategies aid the identification and prevention of post-operative delirium. This is one is the tool where the quality of evidence is high. So for surgical site intervention bundle, these measures have been applied like preoperative smoking cessation, surgical site preparation with chlorhexidine cleansing, and hair clipping as opposed to shaving. Shaving is not antimicrobial prophylaxis with topical intranasal staphylococcal decolonization with mupirocin ointment, and appropriately timed antibiotics and routine maintenance of euglycemia and normothermia. So a number of strategies have been applied across the peri-op continuum, and it is shown to reduce the incidence of post-op surgical site infection. So these interventions are in the preoperative phase, smoking cessation for 4 weeks. Again, same topical nasal staphylococcal decolonization, chlorhexidine-based bathing the night before surgery. Intraoperatively, shaving is discouraged and clipping is preferred. Chlorhexidine alcohol-based solution for skin preparation, and less than 60 minutes prior to incision antibiotic. And routine use of insulin infusion to maintain glucose between 140 to 180, and avoidance of hyperglycemia and maintenance of normothermia. Final, the summary statement is again evidence level of evidence is high in this intervention, and it is said that bundled application of evidence-based best practices has been shown to prevent surgical site infection. So to conclude all ERAS protocols during cardiac surgery, in the intraoperative phase, present-day cardiac surgery ERAS protocols require adoption of patient-centered multidisciplinary pathway. And the care element assessed and reported on in this concise statement can provide a foundation of ERAS program development to ensure optimal care of the cardiac surgical patient. Thanks.
Thank you, Saurabh. Thank you for very, very comprehensive and lucid. Now I invite Dr. Bhuvnesh to talk about ERAS protocol and principles application in pediatric cardiac surgery. So Dr. Bhuvnesh is a principal consultant at Max Super Specialty Hospital, Saket. So Dr. Bhuvnesh, please.
Very good evening, sir. I hope you are able to see the slides and able to hear me.
We are able to hear you and yet to see the slides.
Now, sir.
Mm.
Can you see the slide, sir?
No, sir, it's not yet.
Bhuvnesh, share.
So you need to share your screen side, not share.
Not yet, sir.
No, Bhuvnesh, you are sharing a screen?
Yeah.
Okay.
So click on the share option and then choose the PPT which you want to share. First, minimize it. Minimize the PPT first and then click on the share option.
Okay. Okay.
Yes, now it's visible, sir.
Fine. Sorry for this delay. Very good evening to all of you. We know it's a talk of the town about ERAS these days. And after all the things happening for the adult, we have moved to pediatrics. As mentioned by the earlier speakers, that it was pioneered by Henrik Kellett and the old and ancient
Sir,
concepts.
sorry for the interruption, sir. You have stopped share again. It's not visible.
Okay, ma'am.
Yes, it's visible now, sir. Make it full screen, please.
Okay, sorry for the interruption. And as we know that it was pioneered by Henrik, and the ancient concept of starvation and immobility has now been changed to eat well, move early, lesser stay in hospital, and move back to home faster. And from the ancient concepts of the longer stay in hospital to now the establishment of ERAS society and guidelines and consensus statements, though we have technically advanced as well. And the evidences from adults have confirmed the reduction in morbidity and the length of stay and the lesser post-operative complications. The adult cardiac enhanced recovery program has led to a gross interest in pediatric cardiac surgical program as well as. Though it's quite an older concept, when the Pearson in 2017 had studied almost for the 15 years before that and recruited almost more than 1,000 patients where there was a faster recovery of the patient, and that was largely based on single factor and which was fast tracking. So now what is fast tracking? When it was developed in January 2006 at Gosh, and the strategy was primarily related to the early extubation and the activities around. When we now know that the enhanced recovery program involve not just fast tracking, but the other parameters which provide the faster movement of patient from the hospital. That includes nutrition and pain control and early mobilization and everything. So moving from the adult guidelines, where there were ERAS evidences from 2019, and there was a consensus statement in 2014, and in between, AATS introduced the consensus statement for pediatric cardiac surgery in 2021. Though various articles related to enhanced recovery in pediatric cardiac surgery has been there, but the prime has been in 2021, where this particular consensus statement has defined strategies which were aimed at multimodal management of entire activities like pain and delirium and sedation and analgesia and early extubation. And as usual, there were a lot of recommendations which were based largely to facilitate enhanced recovery. But the most important thing as far as pediatrics or even for adults were concerned was to select the patient. A properly selected and a scheduled patient was a prime motto for launch of this program. And there were multiple components in these kind of all ERPs. And very soon, the Boston Children and Hospital was one of the pioneer in all these, and they have very well mentioned and organized and instituted this program and involved the preoperative and intraoperative and postoperative steps with the multidisciplinary involvement, which begins from preoperative counseling, where a patient could be selected for ERS, ERP program, depending on the disease status, and the family and patients were educated and consulted about the fasting status and nutrition and rehabilitation and anxiety and pain and the movement in the hospital. As I said, that patient safety is priority with early recognition and management of everything. The inclusion and exclusion criteria which was made in the beginning of the program were not absolute. But as far as pediatrics is concerned, stat category 1, 2, 3 were very likely to be included in that, which included acyanotic congenital heart diseases with mild or minimal pulmonary hypertension, coarctation of aorta correction, PDA correction. There wasn't any age-specific criteria, but the more than 3 months of kids were primarily included in the initial stages. But nowadays, neonates are also being included in the enhanced recovery. However, since it is a heterogeneity in the entire perioperative period, the intra and post-operative reasons may result in pause or exit from the ERP. So we begin from fasting, as far as it was little different from the ASA guidelines, where the clear liquids were allowed till 2 hours. Here we consume carbohydrate-rich clear liquid up to 1 hour. In pediatrics, we give it around 3 ml per kg. And we very well know that prolonged fasting induces the catabolic state and increases the insulin resistance. And it does help in early mobilization of the patient. Coming to operative area, where the anesthesiologist has the prime responsibility in this entire success of the program, and we had to select the agents to minimize the impact and techniques on different organ function, rapid awakening, yet to ensure depth of anesthesia and avoidance of awareness. Looking on to all these things, the anesthesia regimens, we typically start with benzodiazepines, though it's not been liked by the anesthesiologists involved in ERAS programs, since they are longer acting and they have the incidences of emergence delirium. The newer agent remimazolam is a new agent, which is the pharmacokinetic and pharmacodynamics are very much suited for the fast tracking. The total IV anesthesia and inhalation anesthetics both were studied separately as well as in combination. Among inhalational anesthetics, sevoflurane was likely be the drug of choice for us for the quick induction, quick maintenance, and quick recovery. And among total IV anesthesia, propofol infusion, remifentanil infusion, since the context-sensitive half-life is good, so they ensure us the quicker recovery. The whole concept of opioid sparing is indeed excellent, since sparing opioid will cause lesser respiratory depression. So infusion of ketamine and dexmedetomidine has been used in the period. From the monitoring point of view, the bispectral index, BIS monitoring, and EEG interpretations were done. The BIS to have a lot of modifiable factors involved in it, with the use of neuromuscular agents and propofol and everything. And EEG was very hard to identify and recognize. Though antidal anesthesia concentration, if you've been captain of MAC of around 1, it was good, equal to BIS of 40 to 60. Careful uses of neuromuscular blockade with monitoring of train of 4 or double burst stimulation was used. So that while doing the reversal of TOF value of more than 0.9 was good, even if we use the cholinesterase inhibitors. Temperature monitoring, largely to prevent hypothermia post-CPB, and hemodynamic management, especially the fluid therapy and inotropes according to the cardiac status. The judicious use of fluids was the prime importance in pediatric cardiac surgery. The fluid overload and poorer outcome was going side by side. So maintaining normovolemia and using different modalities like esophageal Doppler or non-invasive cardiac monitoring were of immense help. On cardiopulmonary bypass, since the majority of pediatric cases are being done on cardiopulmonary bypass, the targets were to target hematocrit, though there was no consensus guidelines on maintaining hematocrit, but 30 to 45% of hematocrit on CPB, and later on to target the hemoglobin of 12 for acyanotic patients and nearly 14 to 15 for cyanotic patients were good enough. And the another important feature was conventional ultrafiltration and modified ultrafiltration using in the intraoperative period with monitoring by an IRS. Later on, the major part of the success of ERP, which was decided on early extubation, be it in extubation on table in operating room or within 6 hours from completion of surgery. Boston specifically had divided ERAS into 2 groups depending on the time period of extubation. ERAS-A being extubated from OR to up till 2 hours after completion of surgery, and ERAS-B from 4 hours to 8 hours. There are different criteria along with the routine criteria. So these patients with pulmonary hypertension or patients with residual lesion or valvular regurgitation, they need special care or extubation may be delayed. Any arrhythmias and bleeding would lead to a low cardiac output syndrome in the postoperative period, so they could better be extubated little later on. We know all the criteria where extubation can be done with hemodynamic stability, urine output, lactates, the oxygenation at FiO2 to around 50% were the prime importance. Delayed chest closure was another reason that we could delay the extubation and not in early extubation category. Less than 20 ml per kg usage of blood and blood products were among that to list into early extubation category. Though the risk factors were involved, as much as there were 0 to 25% in the perioperative period, postoperative period, the risk factors were low weight for age, stat 4 to 5, which were complex cardiac lesions rather than stat 1 to 3. That what we see on the right side of the screen is that hypoplastic left heart syndrome and aortopulmonary shunts had the highest reintubation rate, along with intraped aortic arch or palliative switch. The surgical risk factors, as we know, are the presence of residual lesions or duration of cardiopulmonary bypass more than 120 to 140 minutes was again the risk factor. And as I said, delayed sternal closure as well. Among anesthesia risk factors, uncuffed endotracheal tube was one of the factors, since we have the tendency to use one size bigger uncuffed endotracheal tube to prevent perioperative gas leakage. A microcuffed tube, one side smaller, is good enough. It will also prevent vocal cord edema in postoperative period. Postoperative risk factors were like airway or surgical complications or sepsis or lung reperfusion injuries were few factors involved which could cause reintubation or. So from the surgical point of view, the corrective surgery or the minimal invasive approach, from the other ICU factors like prevention of postoperative nausea vomiting, prevention of delirium, multimodal analgesia, early immobilization, which has positively influenced the incidence of venous thromboembolism or atelectasis. Though extra care used to be needed while the patient being mobilized and making out of bed, since there were risk of orthostatic hypotension or there were monitoring lines and draining tubes. The delirium was one of the major incidents happening in the ICU, with cardiac ICU reporting as almost as much as 50% of incidences. They prolong the length of stay and have the mental burden. The risk factors again were complex CSDs and younger age and benzodiazepines. There were age-appropriate screening tools are there, like pediatric confusion assessment method and corneal assessment. They can be used, and they should be used twice or thrice in a day to ensure. Dexmedetomidine and a total IV anesthesia in particular, they are helpful in preventing the cognitive dysfunction in postoperative period. Pain control is the another modality where multimodal analgesia is used with opioid sparing strategies. Non-opioid analgesics can be used as a preemptive analgesic as well, acetaminophen or ketorolac. At the end of surgery, local infiltration can be done, and regional analgesia in form of erector spiny block or paravertebral blocks can be used. Dexmedetomidine is a perfect drug for us in post-operative period, since it is the highly selective and with good analgesia and anxiolytic properties have largely no effect on respiration. These are the various modalities of regional analgesia where you can use a rectal spiny block, bilateral, ultrasound guided, a single shot, or putting a catheter to have a continuous infusion. Caudal epidurals and spinal and thoracic epidurals can also be used to have a good analgesia. However, with all these activities and recommendations and plans, very recently few evidence and articles were published, and there was a survey happening in Europe where the implementation of ERAS concept was found very low. The possible heterogeneity and clinical practice and more coordinated efforts were needed to implement those. In another article where implementation was very low in preoperative and postoperative management, and it largely was dependent on the operative area and early extubation, be it in operating table or within 4 to 6 hours of finishing the surgery. So to summarize, the team approach is needed and communication is needed. To reiterate the role of anesthesiologist, since they are expert in optimizing preoperative preparation, administering balanced anesthesia, and limiting opioid usage. They can take care of hemodynamic monitoring and lung protective ventilation and fluid balance. Patient safety is more important. No hesitancy should be taken in the longer route of recovery if any step isn't working. And emerging trends like artificial intelligence, point of care ultrasound, and novel agents have come into our role. Focus can help us to put ultrasound guided regional blocks. AI can help us with data analysis. And the most crucial steps is meticulous evaluation and fine-tuning of program on basis of outcome. In the end, it is essential to recognize that enhanced recovery programs are never designed to override the primary principles in taking care. The early recognition and management of complication is needed, if any. Thank you.
Thank you, Bhuvnesh. And now to end the session, I will invite Dr. Rahul Datta. Dr. Rahul will try to sum up and look at the evidence. Already the speakers have spoken about the evidence, Saurabh and Bhuvnesh, but Rahul will try to see it with some new perspective, perhaps. Dr. Rahul. Dr. Rahul is a senior principal consultant at Max Super Specialty Hospital, Saket. Dr. Rahul, please.
Thank you, sir. Thank you for the kind introduction. Good evening, everyone. So, is my slides visible?
Yes, slide is visible, Rahul. Please continue.
Just a minute. So, once again, thank to ICA Society, to Murlidhar sir, to Lakshmi ma'am, and to Chand sir for giving us an opportunity to speak over ERAS in cardiac surgery. Well, my topic, as sir has already said, already the evidence has largely very well described by my colleagues. I am going to say the same evidence in a slightly different way, that why are we in a slow lane in cardiac surgery. So if we see that the idea got conceptualized somewhere in 1990, but for the first time a non-profit organization came up to have the protocols even for cardiac surgery and for non-cardiac surgery somewhere in 2010. Eventually, the first guideline associated with cardiac surgery, a very good set of paper, which was like a best practices, came up in somewhere in 2019, a good 9-year gap. And then the most recent paper has come up somewhere in 2024. So there is something that ERAS has been so widely accepted in all these years. ERAS has found its place in almost all other surgical domain, but has remained somewhat lagging behind in adult cardiac surgery and as well in the pediatric cardiac surgery. So this is not only about India. I am going to share with you a table from a survey which was conducted across USA. 88 different institutions were to participate in this, and if you can see, this table very well reflects that the colorectal, gynae, and orthopedics, they topped the chart with almost around 88% of the centers which said that they have established well-running programs for ERAS in their hospital, whereas neuro and cardiac were like on the bottom of it. Cardiac, almost 9 centers only said that they have 9% of the centers said that they have a established cardiac program running in their institution. So why is the same success which was observed, which has happened in other fields, in other surgical specialty, is not able to happen the same in the adult cardiac surgery or in the cardiac surgery? When I went across the literature, the evidence or the data which I could collect, I have summed up into three different headings. One is the patient population. Maybe the patient population which comes up into cardiac surgery is somewhat different from that in going for colorectal or gynae, and we know them. Majority, almost a third of our patients are like urgent, emergent, where we don't have much of time to carry out the basic principles like prehabilitation and prehabilitation. Even the patients who are like going for a planned surgery, they are usually, few of them would be having a high risk surgery, or they are, because of the disease process, are in low cardiac output space state, so they might not be very fit enough to go for ERAS protocols. And the scientific literature, the two basic documents which have very comprehensively collected the data, in itself they have certain flaws, and as the previous speakers have also spoken, that the strength of the evidence which they carry is not substantial enough, and there are gaps in evidences. So the journey which a patient takes in cardiac surgery, these documents, they cover the patches of it, not a complete journey. So maybe some more evidence has to come for them to find place into cardiac surgery and institutional practices. As we all very well know, that cardiac surgery institutional practices, they take the upper hand, and they are like always more dominant than any other evidence, and institutions, they are reluctant to include new changes into the system. As another very important subset, even if we find a good patient and we have applicability of the scientific literature, operational challenges are very real very real with any program implementation, because the awareness of it, like we can do this in a different way, in a way where the patient can be benefited faster in a faster manner and in a safer manner. Then professional reluctance is there. People, they don't want to bring and adapt to the changes, and this all, the faster doesn't mean that the cost of the procedures will be low. Initially maybe the cost will be high, and to implement ERAS protocol, you need multiple disciplinary teams to be formed. They have to come together for the early recovery of the patient, and this all will need a training, a fixed protocol sets and other thing, which usually the centers are reluctant to carry out. So when I said about the patient population, how is it different in cardiac surgery? So this is again a survey from UK, almost 5 lakh patients operated over a span of like 13 to 14 years. And you can very well see that over the time, the emergency is like 4%, urgent surgery is like 30%. So 1/3 of the patient either go for emergency or urgent surgery. Not much of time is available to us. And elective surgery is almost only in 65% of the patient. Next, coming on to the evidence. So these are the two most important documents which have been published with regards to ERAS in cardiac surgery. The first one, as very well said, is like in 2019, and the other came up in 2024. I will focus here with regard to the methodology which these two documents adopted when they set up these guidelines. So the first document, 2019, the champions from the ERAS facilities were like, they came together, and some 22 topics were selected, and the data was collected, and finally it was analyzed, and level of recommendations were given. But the consensus for giving any level of recommendation was kept around 75%. This document adopted a technique which ACCHA or STS does for their any document. While the document which came up in 2024 is slightly different. Here, the society got endorsed by the STS organization as well, but the data was handled in a different way. Here, the level of evidence was treated as low, moderate, or high. And this low, moderate, or high was like where they said low was like they felt that there is a need of more and more evidence to come. Moderate is like they still were like not very convinced with the available data, and high where they felt like okay, then there's not much now need for a newer data and we can accept that. And but the consensus to reach up to this evidence was dropped down from 75 to 70%. I will not say that this is a dilution so as to make it, but maybe they wanted it that the adaptabilities of these ERAS protocol can increase into the cardiac society as well. So now individually I will take up these both the papers. This is already, it has been very well discussed by all my colleagues, but I will see it here in a different way. So if you see all these they are class 1 indications, and the class 1 indication, only one of that indication is class 1A, is tranexamic acid, and definitely almost, I believe almost it is part of ERAS, but almost non-ERAS also it is being adapted and used in almost all cardiac surgery units. The other is perioperative glycemic control. They have described about HbA1c, and they have also suggested that we should be doing an insulin infusion so as to keep the glucose levels again, but the ranges which is not classically defined. If we go from the previous literature, we can obtain them, but okay, again the evidence which they give to it is like moderate. And again, a well established cardiac center, they always look for and take care of the glycemic control of the patient. Infection, we know surgery and infection is a high risk, and we give a very special stress against the compliance, though it is a part of ERAS, but I believe almost all cardiac surgery, even non-ERAS, they will be giving stress to all these three. Goal directed fluid therapy, well, again, it is a visual. Most of the anesthesiologists during either cardiac or non-cardiac, they try to maintain the hemodynamics of their patient by goal directed fluid therapy. But this document, it emphasizes upon the goal directed fluid therapy, so it misses upon like what are the ranges to be kept to achieve the same, what fluid is to be used. So the comprehensive, so this is something like a very wishful thinking that we should be having a fluid therapy which should be goal directed, but the exact details of it are not so well described into the literature. Again, same is with like the multimodal opioid sparing pain management plan. We know that opioids have their own set of issues, and we want to include a multimodal plan. But that how to reach up to that plan, maybe that the document has been left open so that the institutions can on their own reach up to a plan, maybe individualize it for a patient. But again, the evidence is like coming largely from non-randomized trials, and it is a moderate level of evidence. Same is with hypothermia, and most of the time we have seen that patient temperature drift, and they have, that's why emphasized so that the coagulation can be well maintained. But here again, the level of evidence is like moderate, and largely the data is coming from non-randomized studies only. Delirium screening, here and even in 2024, delirium has found it's increased its footprints, and slowly I think we need to increase and adapt to and increase our sensitivity to the patient, screen them for delirium. Well, the data as such which has been coming from them for to include delirium into an ERAS protocol is not from very strong studies. Stopping smoking, hazardous alcohol consumption, so the grade here given is C, and the evidence is like coming from not from randomized or non-randomized study, so it's like a weak set of evidence. These are like the 2A again, early detection of kidney stress. It's again like something we always want to and do in our patient, but the guideline also here misses upon. They do emphasize the use of biomarkers and to increase the use of biomarker, but how, what level, when to intervene, that something is missing into it. Rigid sternal fixation, which they have said, we know cardiac surgery, largely sternums are closed with wires. The document says in high risk patient we can use sternal plate. I don't know, it's something which surgeons can only answer, but definitely we haven't seen them using, and they are pretty costly. So maybe that's why the reason that much amount of data is not there. Strategies regarding extubation, again the data is coming from weak data set. And lastly, I will move to the 2B, which are like the basic ethos where ERAS was like thought of. You have to do an oral carbohydrate loading should be considered before the surgery. So the level of evidence is weak here, and maybe in cardiac surgery especially, they have been reluctant because they feel that the patients are having gastroparesis. Most of the patient have to undergo a transesophageal examination, which may interfere, though the risk of aspiration is not there. But again, if diabetes and other issues lead to gastroparesis, that the chances of them having aspiration is high. And so the society has kept it as a weak data only. After this 2019, almost the same author published another paper where they discussed about the controversy in enhanced recovery after cardiac surgery. And these were the largely points which they have discussed in this paper, like patient blood management, goal directed hemodynamic therapy, acute kidney injury, opioid reduction, delirium. So these are the major problems which we face in our patient. Usually these problems, they lead to longer stay, longer cost, slow recovery in our patient. But again, they themselves said that the data and the questions which we should do the research, that where to intervene, how to intervene, which is that particular patient, what drugs to be used, is lot of data has to come, lot of research, lot of papers have to come. And therefore they felt that definitely there is gap, and that's why the evidences are on the lower side for this. This is the 2024 paper. Now the society has given a more comprehensive set of document. They have divided the stay of the patient into some preoperative, intraoperative, postoperative, and then multi-phase, and then multi-phase recommendations. So now the document has become more comprehensive. But if we see that still the basic ethos like of the ERAS, prehabilitation and limiting NPO status, even after further span of 5 years, the quality of evidence remains low. They believe that we need more studies to finally say that when should be the NPO status should be called for, or the prehabilitation. Largely they have said that as it is accepted very well, like for 2 hours in other surgical branches, if the patient doesn't have specific factors, we can go ahead with the same thing in our group of patients as well. Intraoperatively, protective lung ventilation, they have given it as a quality of evidence high. That means the role can be beneficial. But as Dr. Saurabh has already said, that the paper on which it has come basically comes from involving basically that it's a meta-analysis where both cardiac, thoracic, general patients, like all the surgical patients are included. And therefore the quality of evidence, therefore I'm not sure how much it is being used in various centers, because largely that data comes from other specialty. Role of T, ventilation on ventilation on cardiopulmonary bypass, again very few centers they do it. Again, the way they do it is also differently. Few apply CPAP, few keep on lower tidal volume, few keep PEEP. The guideline doesn't clearly say which technique is to be used for ventilation on CPB, and the quality of evidence also is moderate here. Avoidance of pulmonary artery catheter in low risk patient, the quality of evidence is moderate. This is something which you will find it goes and interferes with another recommendation with that paper make, that a goal directed fluid therapy should be used. because pulmonary artery catheter is largely used for cardiac output monitoring. It gives us those benchmark numbers which we can give it to the team, which they can chase and eventually give volume according to, and taper and optimize inotropes according to it. But if the use is like restricted, then it's in itself, it's a conflicting statement. Central nervous system monitoring, yes, they say that we can use BIS, we can use an IRS. They help us know hypoperfusion, what levels they do, at what level we should be alerted that hypoperfusion is happening. The document misses on that. Goal directed perfusion, that is something on cardiopulmonary bypass. The quality of evidence is low. They have mentioned that this much amount of oxygen per millimeter square should be given, because it leads to reduction in low risk of AKI is there, and early recovery is seen. But the larger studies, randomized trials are needed to substantiate it. Post-operatively, two strategies for extubation was in intraoperatively, as we can say, within 1 hour. Very difficult for a cardiac setup to have an extubation within 1 hour, and that's why I think they themselves have kept the document quality of evidence to be low. Early extubation strategies, yes, it's getting adopted more and more. And the quality of evidence is also improving. AKI prevention and management, it's like something a wishful thing, where the document says that we should be taking these strategies like avoiding nephrotoxic drug. Role of biomarkers have been described, but what serum levels to look for? Do they really lead to any beneficial effect? What nephrotoxic drug the document largely doesn't speak about them. There are certain multi-phase recommendations which the document has come up with, like goal-directed fluid therapy, opioid-sparing pain management, regional analgesia, blood management program, post-operative atrial fibrillation. Dr. Saurabh has very well discussed them in detail, but they are like big topic in itself. Each important aspect of they have small aspects related to them, and eventually the whole idea or the data which comes from every small thing will lead to finally whether we can really use them. And the pathways or the checklist or something which went to like a flow chart, went to come up with one, if the other failed, the next thing, that is something which is not there. Like post-operative atrial fibrillation, beta blocker role has been suggested, when to come with beta blocker, how much codron, when to give. There are aspects which can be maybe in the next set of documents, they will emphasize upon this. Delirium, as I already said, this is something new. We have to realize it. It's getting sensitivity. We know patient gets stuck up because of delirium in ICU. Very well, they have adopted and given a high risk, high quality evidence is also coming for it, and they have given a good recommendation for it. Surgical site infection, we know infection is a big risk to our set of patients, and it was given a high recommendation in the previous publication and in the newer one as well. So if I compare the two, you will find that prehabilitation and clear liquid up to 2 to 4 hour carbohydrate loading still remains low. The infection, ventilation on cardiopulmonary ventilation, low tidal volume ventilation, and delirium screening are something which have been given high recommendations, and we can look for properly in our set of patients. And this is another paper I just went across through Indian literature, and this is coming from a quaternary hospital in Chandigarh, a teaching hospital, and they look for what are the various barriers in specifically to the program in Indian setup. As you can see that this is a checklist of the ERAS protocol which they used in their hospital. So this paper opens up two, three different issues. Like ERAS 1, which is coming from the guidelines, is that the one which can be or should be used all over, or local ERAS protocols can be generated and they can be used. And if there are 2 to 3 different protocol, can we compare them between each others, that which one is eventually the beneficial one? Maybe this paper has opened up that thing. This paper has come up in Annals in 2025 edition, in November October edition, But the idea of writing this paper was something different. They basically focused upon the obstacles, and as you can see that the heads in which they divided their obstacles were like mental inertia. They said many of the people are not ready for the changes. The team, when we say, it's not doctors, the sisters, many other staff supporting physiotherapists, dietitians, they are reluctant, they don't want to change. Memory failure, easily people say that I just forgot, one step missed, and your protocol is like breached. Leadership failure, people on the top, they feel that okay, we will be doing it in some other way. Lack of motivation, people feel, why should I be doing this is more strenuous. Hierarchy, the top one in the place decides how the things are going to run. Maybe sometimes conflict of interest is also there. And resource limitation. So we have to see, in a country like India, where we are very cost sensitive, sometimes external plates, use of PA catheters, patient blood management program like use of erythropoietin, giving pre-operative checks for anemia, maybe resources are not there. Maybe we will not be able to totally capture the spirit of the ERAS which the guideline proposes, maybe. So another thing which ERAS proposes is that it leads to cost reduction. So I went across the literature and I took up this paper. It is from colorectal surgery. The reason I took it, because colorectal surgery has a very matured ERAS protocol, and you can see that definitely the paper says it leads to reduction, a post-operative cost reduction. But in the pre-operative phase, the cost is high because patient has to undergo various screenings. They have to go under prehabilitation. Maybe that is something to be looked for. The teams have to be trained. They have to look for various other things. This is a paper which I have taken from a cardiac surgery, minimally invasive cardiac surgery, a surgical protocol. If you see that largely the cost, it's again a cost thing which they have looked for. So the cost remains same almost between ERAS and non-ERAS, inside OR and in general ward. The reduction was there in ICU and total hospital stay. They emphasize that the benefits which we see is just because of the shorter duration of the stay of the patient in the hospital. While another tip, this is another chart which I have shared. You can see the cost of few things, it rather goes up because of the ERAS, not it reduces. Like it doesn't reduce for everything, it increases. Like physiotherapy, the cost may go up. You have to make your patient undergo mobilization. There are certain laboratory services which you will be doing more. The X-rays will be needed more. So this one idea that ERAS, if I start, will lead to reduction in the cost. Maybe initially you will have to invest more, and then you will have to reap the change. Finally, when the program will mature, you will have the benefit coming of it. So I will conclude here my presentation with this, that ERAS aim is to start strong. We have to start strong with our patient, prehabilitate, start strong, and end stronger in our patient. It's just the repetition of the slide. So patient population, as I said, maybe high risk, maybe urgent, emergent, maybe, but we have to look, the intent has to be that in a way we have to look for every opportunity, every step where we can bring that the guideline into, or maybe that maybe those topics, and benefit our patient. Scientific literature, yes, there are evidence is an issue, gaps are there in evidence. Institutional practices, they play a role, so we can navigate them. We can use the best practices, and evidence and gaps and evidence is something where the science matures slowly. With our with this will always occur. We will find that the set of changes are not working. We will analyze the data, some newer good things will come. Maybe we should use whole bundle and see that the bundle benefits, rather than applying one or two principles of ERAS. If you see 2024 ERAS paper, it is basically not an enhanced recovery. It's a set of document for a best practices which you can assume for or do in our cardiac surgery patient. Institutional practices, definitely, even the guideline doesn't say that you have to follow this in thus in this one way we should create local ERAS protocols. We should see what works best with our teams and in in our institutions, and maybe we can achieve the same success. Challenges, they are very important. They can lead to failure of any protocol, and here team building is very essential. We have to build team, dedicated team, make them understand the benefits of the principles of ERAS. We have to create pathways like patient blood management. We should know when to intervene, what drugs to be given, when to be given. We have, maybe initially it may require a certain investment, but this investment will create both the benefits in monetary term and will lead to maturity of the staff to handle sicker patient in a different way and in a better way. And effective communication, we know that newer changes are not so well taken. We have to interact with the teams. We have to create multidisciplinary team eventually to make ERAS success. I've not like a pro to ERAS or a con to ERAS, but definitely ERAS promises better for our patient. Maybe we should try to navigate and try to look for how we can make it successful in our set of patient. With this, I will like to thank IC Indian College of Anesthesiology, Muralidhar sir, and Dr. Lakshmi and Chan sir for giving us an opportunity to speak over the ERAS in cardiac surgery.
Thank you, Doctor. Thank you, Rahul Datta. Yeah, you explained us very elaborately, and definitely there is a consideration or there is a point to consider the patients who are undergoing cardiac surgery regarding the ARS protocols. And definitely with the coming up of these minimal invasive, where we are extensively started doing, I think so the post-operative, with the use of multimodal approach with non-opioids or a regional techniques, definitely has gained popular. And I think so in the coming short of either it must be a few 1 or 2 years, I think so it definitely is going to gain. The ERAS protocol is definitely going to it will be recommended in every aspect of these type of surgeries. So
Thank you so much. Thank you, Dr. Lakshmi, for that wonderful comments. I request the speakers and the panelists to switch on their videos so that we can see each other as we discuss. We have about 15 minutes to go to close the session. Any comments or any questions may be addressed during this point of time. From my point of view, all the four presentations were brilliantly done, and I especially like the last one where the discussion was about what are the controversies and what are the challenges. Most often we don't have time to prepare the patient, and there are institutional practices, and more importantly, professional resistance. And another important point mentioned was about 30% of the patients whom we operate are emergency or urgent. So there are absolutely no time for us to get the patient ready for the surgery in terms of pre-rehabilitation. And the surgeon's opinion is also has to be taken consideration. And most often when I plan early extubation, somebody from the surgeon side pass on a message through a junior colleague saying that not to extubate, something like that. These things do happen. So there is resistance from the some of our colleagues. So we don't, if somebody says like that, you don't feel like extubating them and following the only fast track pathway. And also it was mentioned that physical training has to be done. It's impracticable in cardiac surgical patients. They all have breathlessness on exertion, and they are having, say, critical lesions in the coronary arteries. There's no point in is saying that we need to physically train the patients. Maybe very, very few patients may be fit to be physically trained, but in general, I don't think that's a viable option in cardiac surgical patients. With that, I open this discussion, this platform for discussion, and There's one question about what is their experience with pre-operative carbohydrate drink? I think
Uh,
this has to
yes,
be
sir.
by Rohit.
Yeah, so it was covered in the prehabilitation part. Actually, as I mentioned in the last slide, the level of evidence is still moderate, and they say the data is limited. But advantages definitely theoretically, it definitely reduces the insulin resistance, and it's kind of reduces patients' anxiety. Patient will feel less thirsty, and less hunger will be there. So definitely, it should help. It should help in the post-operative early recovery. Definitely.
Yes, yes. Rajesh, your comments?
Sir, what Rohit said that if I'm a patient, I'll definitely feel happy. So happier patient with endorphins, more engaged patient, more intent, and it is a subject of ongoing research. We in our institution, we are conducting a study right now. Rohit is a guide of that study, and we are using carbohydrate drink. So soon we should have some more answer.
Sure, sure. Yeah, yeah, very well said, actually. In the morning, you like to have something to eat or drink a little bit, otherwise, you feel uncomfortable. I think the same experience may be felt by some of these patients who come to theater after overnight fasting. Other comments? Anybody would like to comment or ask any questions? What is the role of NGAL as a marker of AKI? I think this one has to be answered by Saurabh, if I'm right.
Saurabh or Rohit, because of prehabilitation. So any of Saurabh or Rohit can choose to answer it.
Both
That
of
is,
them, one after the other, maybe.
yeah. Is NGAL used as a biomarker for in ERAS?
NGAL as a biomarker.
Sir, according to the
Neutrophil gelatinase associated lipocalin, that is
yes,
NGAL.
sir.
And
Yes,
it
sir.
is a marker of renal injury, and it is detected in the urine. You have to take the sample of urine at the end of serial estimations can be done and then see whether it is going up. Yes, yes, please carry on.
So definitely, NGAL is used for to detect acute kidney injury, but as per the guidelines given by the ERAS Society, it is not included as a serum biomarker or for preoperative kidney injection. But definitely, NGAL can be used because the markers which they have advised, it is given by the Kidgo Society, and I think if after creatine we can use it to detect kidney disease.
Yeah,
Dr. Muralidharan sir has published this paper on regarding
yeah,
this.
yeah.
So you
Yes, yes, yes. We did look into the NGAL as a biomarker of kidney injury in cardiac surgical patients, and we found that sometimes even non-specific conditions can cause NGAL increase. For example, sepsis or inflammatory diseases can cause increase in NGAL production, and it may be confused with the kidney injury. So that's why it has not been becoming a recommended practice to look at it. And as correctly pointed out, if there's no guideline recommendation for this, so it's not being done. But it is one of the biomarkers which have been mentioned as markers of kidney injury, because creatinine is a late marker, and also because of the hemodilution, the creatinine may go up because of hemodilution. It may not actually reflect in the serum levels. That's how we are not able to use serum creatinine as a true biomarker in terms of acute kidney injury in most of the cases. We'll see. Any other comments or questions? Parimala, do you want to say anything? Dr. Parimala is here. Parimala is the Chief of Cardiac Anesthesia at the Jayadeva Institute of Cardiac Sciences in
Good
Bangalore.
evening, sir.
Good evening. Tell me, ma'am.
Yes, we have also been practicing enhanced recovery even in adults and pediatrics. And as Dr. Lakshmi said, for minimally invasive surgeries, it helps in early, not just early extubation, even early recovery from ICU. Early, once we extubate, then other things also happen faster. Removal of
Yes.
ICD and mobilization, everything is
Yes.
faster.
Yes.
So, and patient satisfaction is there. We have seen both adults and children that they are so comfortable
Yeah.
with regional blocks as well as multimodal analgesia. So, patient satisfaction is also better. So I
Yes.
think we all should, in selected cases, we should practice enhanced recovery.
I agree. I agree. Actually, someone was mentioning about thoracic epidural. I think it's not the in thing now because we have so many regional blocks.
Safer.
Yeah, regional blocks have come up and they're much safer and effective. So thoracic epidural has the inherent danger of epidural hematoma and logistic difficulties in terms of placing the catheter the previous evening or
Yes, sir. I think a day before the surgery, we can put. We have already stopped the clopid and.
yeah, but that's
Like
logistic
this,
difficulty. But
yeah.
suppose
But the study, which is the definite study, we found is
that must be
on.
old. When was it published?
I
I
think
think
when.
thoracic epidural, to my knowledge, I mean, please correct me, it's no
Yes,
longer
sir.
being done for cardiac surgery because several regional techniques have come up.
Yes, sir. Nowadays, many chest wall blocks are there. Even paravertebral have some issue with the bleeding and other things. But erector spiny blocks and SAB blocks are safer than
There are at least a dozen
paravertebral.
blocks which can be given, which effectively all of them are quite good.
Sir, I
And
agree with you. The thoracic blocks have gone into kind of out of vogue because they're difficult to put. There is the associated stigma of hematomas and paralysis. So they are kind of outdated. Now regarding the my comment on this, so I we have already spoken so much. I think the carry home message for the audience, or a message which I'll carry home, that
yes,
ERAS concept, ERAS is a very beautiful concept. There is no doubt about it. But as Bhuvnesh said, that we cannot lose the sight of patient safety. We have learned with lot of difficulty a safe method, kind of some safe pathways to take patient home,
yeah,
which is very complex and involve many stakeholders. Now Iras talks about optimizing that process. So that is where since though Iras is very nice, but safety has been achieved with difficulty. So we need to proceed on the path of Iras. The entire team has to proceed together. What Rahul said, that we have to forget our egos, communicate effectively, create pathways, and have the intent. So if we see from Bhuvnesh's statement, safety cannot be compromised. We have learned with our inefficient and empiric ways, and we have to move towards a more objective, balanced, reproducible, and predictable ERAS pathways.
absolutely.
This is the carry home message for all of us, because here I can see the leaders in the specialties, the leaders and would be leaders. So perhaps a generational change needs to come, that leaders have to believe and they have to push for it. This
Yes,
is
yes,
my statement.
absolutely. Absolutely. As correctly pointed out, 30% of them are more or less emergent procedures or urgent procedures. Another 30% are sick patients who are not fit for interventional procedures. So they'll end up with cardiac surgery. And if you go by these numbers, up to 50 to 60% are not really fast tracked, in the sense that they need overnight ventilation, and then remaining 40% only are available for these type of protocols which can be applied. That's I think we should keep in mind. And also, my one of my problems is that when at the end of surgery, patients, especially in occupancy, the patient's temperature is 35 or 34. So this it's really not feasible to extubate. You have to wait for a couple of hours till they become warm and then extubate. Our theaters are quite cold, they keep it at 18 or 19 degrees. And at the end of surgery, the patient's temperature is 34 or 35. You don't feel comfortable to extubate them.
Yes,
I don't have experience.
and chances to make patient optimize preoperatively are also it's a very many times we don't find any reason to postpone, or we don't find any time
Yes,
to
yes. If
optimize a
you
patient.
postpone, the patient
He-
will go to some other center. So that
Yes,
was
sir.
also there.
So to optimize hemoglobin levels, albumin levels, and other things, smoking cessation, these all take time, and
Yes.
So, but
very few centers.
my only submission here is yes, everything correct. But as Rahul said, IRAS is more about like a religion. It's intent. So IRAS with intent is there. IRAS is perhaps not a monolith. It's not all or none. IRAS has so many small components that even if we miss some component, we can latch on to some component. So first we need to believe in IRAS, and we need to latch on small components whenever possible. So that perhaps may be the answer.
Mm. But I was wondering the protocol from Chandigarh, which said that lignocaine and esmolol infusion to be given. I have never used it. What is the experience with
Perhaps they are talking about during intubation.
during intubation? How does
Perhaps
that
Rahul.
help in early recovery?
Sir, sir, that
Rahul,
paper, yes, so that paper was like the data collection started from 2017 onwards.
I
Though
see.
the publication has happened this year and the study lasted for a span of 4 years, maybe the first set of our guidelines from IRAS came somewhere 2019. So they started early.
Mm,
Exactly, they did what they do. I think their
right.
aim was like that's what I was trying to communicate. Maybe we will find centers with a very different things which they believe that this lead to early recovery in their set of patient, and it will eventually challenge and maybe conflict with the ideas which the IRAS society is putting up. maybe
Yes.
maybe we are extubating our patient in 6 hours with the protocols which we have built up locally, which are equally safe enough and good enough like the IRAS society. So that's what the point when I mentioned that paper. And the second part,
Very interesting
yes
piece of
sir.
information. Thank you so much. And I think it's time to wind up. I would, on the behalf of, if there is any pressing question or burning question, last one, we can take it up. Otherwise, we need to close. Mm, it's my duty to thank Dr. Rajesh Kumar Chand for being a champion in this webinar, taking the lead role to organize this seminar. We would like to thank you from on behalf of the Indian College of Anesthesiologists, and all the four speakers have done very well. Dr. Rohit, Dr. Saurabh, Dr. Bhunesh, and Dr. Rahul Datta, very well done. Thank you so much for being with us. And Dr. Lakshmi, thank you for joining us
Thank you,
Thank you,
sir.
sir.
despite
Thank you.
short
Thank you.
notice. Thank you so much. And we look forward to having you once again. And this being the first webinar of the year from ICA, I would like to wish all of you a happy new year and prosperous and healthy days to come. Thank you so much,
Thank
and
you, sir.
looking forward to
Thank you,
seeing
sir.
you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you,
Take care,
sir.
sir.
Thank
Good
you,
night, sir.
IIC, for your kind cooperation, and Venkatesh for the logistic arrangements.
Good night, sir.
Good
Good
night.
night.
Thank you.
So, thanks to all the dignitaries present here. Client is really glad to have all these brilliant people to the session today, and I hope you all had a seamless experience. So, with
Thank you. Thank you.
everyone's permission,
Before
I'm
actually we close, I would like to request all of you to participate in Sunday breakfast sessions. Those are being done by eminent speakers, quality is being maintained. Thank you so much, and looking forward to seeing you again.
Thank you, sir.
And Muralidhar, sir. Okay. So we are concluding the session in your fatigue. Thank you so much. Good night.